All right. Thanks, guys. We might get started. So good evening. Before we begin, I'd like to acknowledge the traditional owners of the land on which we meet today, the Wurundjeri people of the Kulin Nation, and pay my respects to the elders past, present, and emerging. Welcome to the inaugural event by the Australian Students' Society of Haematology, or ASSH for short, a professional society for university students interested in learning more about blood and blood disorders, which has a threefold mission to improve university students' understanding of core topics in haematology, foster interest amongst students in the discipline of haematology, and support and advocate for haematology research. My name is Victor, and together with the team at ASSH, I am proud to bring you the first of a series of ASSH seminars lined up for this year. Today's seminar is entitled Approach to Anemia in Patients and the Population. Often underappreciated, anemia affects roughly a third of the world's population, with half of the cases attributable to iron deficiency. It is a major and global public health problem, and even as medical students, we often see patients in the clinic and on the wards presenting with low hemoglobin for investigation and or management. How should we work such a patient up? How do we use the test results to determine the etiology of a patient's anemia? What are the mechanisms underlying the different causes of anemia? To answer all these questions and more, it gives me great pleasure to welcome Dr. Sant-Rayn Pasricha. Dr. Pasricha is a hematologist, molecular biologist, and epidemiologist. He currently serves as head of the Population Health and Immunity Division at the Walter and Eliza Hall Institute of Medical Research, and as a consultant hematologist at the Royal Melbourne Hospital. His work revolves around the basic biology, clinical diagnosis and treatment, and public health control of anemia. In the lab, his group studies aspects of gene regulation, of red blood cell production and function, and of mechanisms of regulation of iron homeostasis. He has consulted extensively on anemia control policy for the World Health Organization and the Australian Red Cross Blood Service, and is currently leading a program of large randomised control trials investigating the health benefits and risks of universal iron interventions in South Asia and Sub-Saharan Africa. Would you please join me in welcoming Dr. Pasricha?
Great, thank you for that very kind introduction. Can you hear me if I stand here and hang out over in this corner? So just firstly, I'd just really like to congratulate all of you, and particularly Victor and his team, for putting together this society. This is an amazing initiative, and it's great to see so many of you here tonight. I think, you know, I'm a hematologist. When I was training as a medical student, let alone as a trainee, as a junior doctor, there was nothing like this, and this is a really exciting step forward. And you should all stay in touch with Victor, and then through that with me, and we'll see how we can help you in other ways as a clinical hematology community as well as you guys go forwards. So I'm going to talk a little bit about my favorite topic, which is anemia. And anemia is, as you heard, one of the most common disorders in the world. It's seen, you know, it's thought to affect 273 million babies around the world, children under 5, and you can see, and about 500 million women. You can see that that anemia is concentrated in these really poor parts of the world, in Sub-Saharan Africa and in parts of South Asia and Southeast Asia. Indeed, in parts of Sub-Saharan Africa, the prevalence of anemia approaches 60 or 70%, really catastrophically high prevalences. And the prevalence of anemia, this is just showing that the prevalence of anemia in women and in non-pregnant women. The global burden of disease considered that anemia accounts for about 9% of the total disability from all conditions around the world, from all the different conditions around the world. So what do we mean when we say anemia? Well, anemia is considered a state in which there isn't enough of a red cell mass to meet the oxygen requirements of the tissues. But more prosaically, it's really just defined as a reduction in hemoglobin below a concentration that has been defined. Now, there's many ways of defining anemia, and one of the most important realizations is that there may be a patient with a hemoglobin below a certain threshold, but you have to think about the patient. So some people can really tolerate a lower hemoglobin for a lot longer, and other patients really suffer as soon as the hemoglobin even goes below something that might even be in the normal range. what I'm going to talk about first is a little bit of an introduction to the causes of anemia and the pathophysiology of anemia, and then how we work it up. But I know that a lot of you guys are quite early in your medical training, and this will not necessarily make a whole lot of sense yet. So you can just take this as a sort of a bit of an entry, and then you'll get to revisit this and study this more and more as you go forwards into the future. But hematology is actually a pretty easy specialty, and anemia in particular. You're either anemic because you have reduced red cell production or because you have increased red cell destruction, in other words, reduced survival. And that can either be because you're breaking down your red cells or because you're losing your red cells. So what causes reduced red cell production? I'm just going to hit you with a list here. So the first is iron deficiency anemia. So not having enough iron to synthesize hemoglobin, importantly, the heme component of hemoglobin, and that causes anemia. You can have anemia of chronic disease, which is an inflammatory condition. Now, anemia of inflammation actually causes anemia in a similar way actually to iron deficiency, in that it withholds iron from the bone marrow. You can have reduced erythropoietin production. So erythropoietin is a hormone produced by the kidney in response to a sensing of hypoxia. And that and erythropoietin signals from the kidney to the bone marrow to stimulate increased red blood cell production. You can have bone marrow failure. So the bone marrow itself is diseased. And here, this can occur because the bone marrow empties out and there's reduced hematopoietic cell production. And that's most commonly seen in a disease called aplastic anemia. And there you usually see a pancytopenia, so not just anemia, but also a loss of white cell and platelet production. It can also be that you have your bone marrow replaced by particularly a malignant clone. So for example, in cases of leukemia, or it can be because of replacement by other types of cell or organisms that shouldn't be there. And two classics would be replacement by other cancers, so metastatic cancer, or in infections such as tuberculosis. And it can also be because of inadequate red cell maturation, or what we call dyserythropoiesis. And here, whilst the bone marrow is trying to make the red blood cells, they just don't mature properly, and so they're not functional. And here you see that in nutritional deficiencies such as B12 and folate deficiency, in myelodysplastic syndromes, which is a sort of a precursor to some forms of acute leukemia. You also see it in genetic conditions such as thalassemia, and also you see it in some other genetic conditions called, a relatively rare genetic condition called congenital dyserythropoietic anemia, CDA. What about increased red blood cell destruction? So here, this is associated with hemolysis. So hemolysis refers to when red blood cells are being broken down in your peripheral circulation. And this can occur because of inherited conditions. And here, it's basically anything in the red cell membrane can go awry. So it could be anything in the red cell can go awry. So it could be the membrane. And here you can have hereditary spherocytosis or elliptocytosis. It could be red cell enzymes such as G6PD deficiency. And it can be hemoglobinopathies such as sickle cell disease or thalassemia. And there can be acquired conditions. And so here the classics are warm immune hemolysis, which is an antibody directed to the red cell that causes it to be destroyed in the spleen. Microangiopathic hemolytic anemia, which is probably the most interesting hematologic disease. So you can go and Google that one later, but TTP is a disease where you have increased you have peripheral destruction of red cells due to production of, due to endothelial activation, and that causes a severe anemia and thrombocytopenia. Malaria, and today there was actually a case in the hospital of a patient who returned from Uganda with 12%, so every 1 out of every 8 red cells in their blood had a parasite in them. And mechanical. So I don't know if any of you are marathon runners, or the classic is the bongo drummers, but let's call them marathon runners. They call it March hemolysis. So basically just contact trauma can actually cause blood cell production. We call that in the blood vessels. It can be hypersplenism. So there's many things that can result in a big spleen, and it can be primary blood diseases, but it can also be secondary to a range of other conditions such as portal hypertension associated with liver disease. And there, that just causes red cells to be clogged up in your spleen. And of course, instead of red cell destruction, it can just be you lose your blood onto the floor. And that's a very common cause in a hospital like the Royal Melbourne Hospital, where it's a trauma centre. And so all those helicopters are usually bringing in trauma cases, and those patients will be anemic because of acute bleeding. You can also get it in gastrointestinal bleeding as the other major cause. And then chronic, in the chronic sense, bleeding is more likely cause anemia via iron deficiency. So this is the initial workup for anemia. Now, this is a very clinical list of tests, and I think each of these, I'm not sure whether you guys will have come across this stuff yet, but I'll just take you through the tour. So this is what I do when I meet a patient who's anemic. So the first thing is obviously I found out they're anemic because we had a full blood count. This is done on an automated analyzer, and it gives us the hemoglobin concentration, the red cell size, the amount of hemoglobin in a red cell, and the reticulocyte count if you ask for it. And that's the young red cells. We do a blood film, which allows us to look at the blood and try to discern if there's morphologically any changes. And then we look at other tests. So we can measure, and this will usually be done biochemically, so iron studies, B12 and folate, inflammatory markers, most often the CRP, a hemolysis screen, so looking at a bunch of biomarkers associated with red cell breakdown. The haptoglobin mops up heme and is suppressed in hemolysis. The lactate dehydrogenase is elevated in hemolysis because it's an intracellular enzyme. Bilirubin, which is of course a marker of heme breakdown in the liver, and the direct Coombs test, which tells us whether there's antibodies stuck to the red cells. We can also test for hemoglobinopathies, and we can do that by hemoglobin electrophoresis or even genetic studies. And also we can test for the overall organ function of the patient, so the renal function and the liver function. So this is how I sort of start thinking about anemia when I meet it. So there's many different classification systems, and you'll meet them all over the place, and people try to break down the cause of anemia. It's one of those things that you can try to memorize the cause, and you'll be asked in your exams, how do you discern a cause of anemia? But actually in the end, you sort of test for everything at once, and the cause may or may not become apparent. And in patients in the hospital in Australia, they usually have multiple causes of anemia all happening at once. No one ever just has one disease unless they're young, and there's not many young patients. So anemia the way I classify it is the first thing I'd think about is the size of the red blood cell. Are the red blood cells small, microcytic, normal, normocytic, or large, macrocytic? So it's pretty easy. And if they're small, we look at whether then the two big causes are iron deficiency or thalassemia. If they're a normal size, then the patient's just bled. So that should be evident, but sometimes it's not. It could be that their bone marrow is not working properly, or it could be that their bone marrow is working too much. In other words, are they responding? And there you can look at the reticulocyte count. And so a patient with low retics, you think about the bone marrow. And a patient with increased reticulocyte count, then you think about red cell breakdown, so you can look at hemolysis and look at those causes that I described before. And finally, if the red cells are big, then there's two sort of ways of categorizing that. Are the red cells really, really, really big? For example, a mean cell volume above 110. Those patients usually have B12 or folate deficiency. If they're not that big, so they're less than 110 but above, say, 95, then there's a series of other macrocytic anemias, non-megaloblastic causes. And here, we sometimes think of hypothyroidism, but the biggest one in Melbourne will be liver disease. So I'll just show you a few blood films that you'll be able to have a look at. And so this is a normal blood film, and what you can see here, there's a neutrophil in the middle, and then this. I don't know whether this works. Does this? Oh, here we go. Can you see the cursor? So this is the neutrophil. These little things here, anyone know? Yeah, those are platelets. And then these guys are red cells. And a normal red cell has a little bit of central pallor, just like that. This guy here, what do you reckon that one is? That one's a bigger and purpler. That's probably a reticulocyte because it's got a bit of RNA in it. So, and it looks a bit bigger than the others. So that's what a normal blood film might look like. So this is a film with iron deficiency. So this is a lymphocyte here. And notice the cells look a bit smaller than a lymphocyte. So that's a very gross morphologic test of whether a red cell is small, if it's smaller than a lymphocyte. And you can see they've got all this central pallor. So they're very pale and they look, very hollowed out. So that implies that they haven't got as much hemoglobin in them. So that's consistent with iron deficiency. And the other thing you often see in iron deficiencies is pencil cells. They look a bit like pencils. This is another classic. So this is sickle cell disease. And so these are the sickle cells. You can't miss those. And these are obviously, sickle cell is seen in patients with either a homozygote sickle cell state or a compound heterozygote with another hemoglobinopathy. Hereditary elliptocytosis, this is my favorite blood morphology because it's just so striking, but the patient's usually completely well. So they hardly ever know. So you always unexpectedly uncover these. And these are where the red cells have a membrane protein anchor mutation. And they basically have these sort of, well, it's obviously what they have, elliptocytes. So they have red cells that look like these little UFO type shapes here. And the key thing is that almost all the red cells are affected. And some of these patients have a hemolytic anemia, some of them have big spleens, and some of them are totally fine. Here's another one. This is a warm immune hemolytic anemia. So the first thing to say here is this patient is trying to respond because they've got a few of these reticulocytes here. And what the classic cell you see here is, say, this one here, missing the central pallor quite completely, maybe this one here as well, maybe that one there. And these are called Spera Sites. And that's because these cells have had the antibodies bound to them. They've made a journey through the spleen, and the spleen has sort of ripped off little bits of membrane, reducing increasing the surface area to volume ratio, and getting rid of the central pallor. This is a case of malaria. So the arrows are pointing to something quite obvious, which is the ring stage malaria sitting in the red cells. So this is what a case of malaria looks like, and we saw that today. And obviously common in return travelers or if you happen to work overseas. And this is microangiopathic hemolysis. So this is where you get this sort of deposition of fibrin in the small vasculature of the capillary vasculature. And basically it acts as though, I don't know if you've seen Mission Impossible and all the lasers and they have to kind of jump through the lasers. Well, the red cells don't know how to jump, so they just go straight through it and they get sliced. And so you see all these sliced red cells like that, and like that, and like that. And these are just red cells that have basically been put through a sort of a set of blades, and they just get sliced to pieces. So the patients have this severe hemolysis. And the other thing that's totally missing on this blood film is platelets. So they often have a very severe thrombocytopenia as well. So now I'm going to shift focus. I'm going to so that was an overview of anemia, but what I want to talk to you about now for the next few minutes is more about iron. That's the area that I work on, and I'll talk to you a bit about iron. It's probably the most common medical disease in the world, and something that you guys will encounter in your clinical practice, even as super subspecialized hematologists in a few years' time. So anemia and iron deficiency is common in Australia. This is a study we did with the blood service, and what we found was that even among people who've never given blood, so new donors, about 7% of blood, 3% of blood donors were anemic. So these are healthy-ish people, and 7% of them have iron deficiency. And if you look at women, 12% of women were iron deficient. So these are people who've never given blood. So they're very healthy people who thought they were fine, and 6% of them were anemic and 12% of them were iron deficient. Much less common in males. So what does iron deficiency cause? It causes symptoms, and these are the symptoms of iron deficiency and of anemia, but it makes people feel fatigued, makes people feel short of breath on exertion. They might have a headache, they might have palpitations, they might have ringing in their ears. Some people talk about hair loss and dry skin, and we do see that. And there's a fantastic phenomenon called pica. And I don't know, does anyone know what pica is? Anyone come across that? Eating pies, eating ice, yeah, eating ice. Yeah, that's right, eating ice. So that's so eating ice, eating soil, eating dirt. In Australia, people might do it by just eating oats, which they haven't cooked. You know, they get that sort of feeling. So, so pica is a very common symptom associated with iron deficiency. And then there's potentially longer term implications. For example, women who are iron deficient in pregnancy might have, it's known that they have babies with lower birth weights that might be born more premature. And there's potential implications in children that I'll talk about later on child development, cognitive development. Ultimately, iron deficiency is one manifestation of disordered iron balance. As I said, hematology is pretty easy and iron's pretty easy. You either have iron overload or iron deficiency, and that's basically an imbalance between your absorption, your utilizations, and your losses. So the mechanisms of iron deficiency, and so what I'll talk about now, the mechanisms of iron deficiency and how it can go wrong. And then actually I'm going to talk to you a little bit, because it's an exciting area, about some of the new drugs that are coming to manipulate iron status. Because some amazing discoveries have made it possible to not just treat iron status with iron, but actually with molecular targeted therapies. So I'll show that in a few minutes as well. So firstly, the mechanisms of iron deficiency. So iron deficiency implies you've got reduced iron stores, but how do you get there? Well, that can be because of problems with your intake, with your absorption, your utilization of iron, and so imbalances there. Or it can be because you've lost iron. And when I say lost iron, I usually mean blood losses. So how do we get iron in? It's nutritional. So we eat, and there's really two sources of iron in the diet: non-heme iron, which implies which are vegetarian sources of iron. So predominantly in nuts and beans and so forth. And the absorption of iron from those sources is less efficient, and it's suspect to inhibition from different other compounds that you might eat. So in particular, phytates, which are found in cereal crops, polyphenols found in tannins, and calcium. And it can be enhanced by acid and also by the ingestion of meat at the same time. So I don't know if any of you have ever consumed an Indian diet. Obviously I have. And an Indian diet is uniquely designed to make you iron deficient because people consume phytates in the type of wheat that Indians like to eat. They eat lentils, which is the alleged source of iron, but it's unsprouted, so it's got phytates in it. Then they'll wash it down with a cup of tea, which has got a lot of milk in it. So the polyphenols contain tea. The tea contains polyphenols and calcium, obviously, in the milk. So the iron absorption from an Indian diet is really not well designed. Meanwhile, the other source of iron is heme iron. So this is iron contained in meat, and this is where you have, and here you have more efficient absorption of iron from a meat source. But actually, we don't know a lot about the mechanism of iron absorption from meat or from heme iron. Okay, so once you've eaten your food, the next place it has to get to comes down your esophagus. You guys know this, and it gets to your stomach. And your stomach is an important area of action for iron absorption because it gets the iron in your food ready for absorption. So this is your stomach. I'm guessing you guys have done anatomy. So you've got the antrum and the fundus, and the two important things they do there is the fundus makes hydrochloric acid, creates an acidic environment. And what that does is that keeps the iron soluble for absorption in the duodenum. So if you lose this acidification, you lose the capacity to absorb iron. And so there's a lot of diseases that the gastroenterologists look after that cause failure of acidification, and there's also a few medications. So atrophic gastritis, so H. pylori causes this, and autoimmune gastritis, which is commonly seen in elderly patients, causes this too. These patients may become iron deficient. Antacid medication. So almost 100% of the patients in the hospital are on antacid medications, and the actual mechanism is to raise the pH, and in so doing, they'll impair iron absorption. And not so much done now, but in the not too long ago, and there's still plenty of patients running around with it, is gastric bypass surgery, which is basically a way of bypassing the stomach. So basically connecting the upper stomach through to the duodenum and to try to reduce nutrient absorption from the diet so people can lose weight. And of course, that causes iron deficiency too. The next issue in the stomach is blood loss. So the stomach loves to bleed, and it can bleed because you gave the patient aspirin. And there was a big trial of giving people aspirin to see if it improved cardiovascular outcomes that was done at Monash. They randomized 16,000 people, hoping to improve life expectancy, dementia, and so forth. They didn't, but they did increase hemorrhage from the stomach. Peptic ulcer from H. pylori, and of course the big one, gastric cancer. So these are the things that are going through our minds when we meet a patient with iron deficiency, especially an older patient. The next place is, of course, the duodenum. So the duodenum is where the action happens. This is where iron is absorbed. And the two diseases here that we really think about now are celiac disease, and that is a disease of an immune disease, obviously caused by gluten that causes effacement of the absorptive area of the intestine, and also obviously in developing countries, hookworm. So there's a study that was done trying to really nut out how much does celiac disease contribute to iron deficiency. And what they were able to say at the end of the day was that about 1% of the population have celiac disease, but about 3% of people who have iron deficiency have celiac disease. So that's not rare, and now we test everyone with iron deficiency for celiac disease. And the role of hookworms. So this study was done in Tanzania, and this study just basically showed that most people don't have a lot of worms, but the people who do have a lot of worms bleed a lot from them, from their intestines. So that's a blood loss, and those patients do have so the more eggs you have in your poo, that implies the more worms you have, and you start seeing quite a lot of iron deficiency in these patients. So the next place to think about here, so this is not a site of absorption, this is a site of excretion, is the colon. Now, the colon is a critical issue for iron deficiency because the colons bleed. And the place colons bleed, the thing that colons bleed from is usually neoplasia. So the two important diseases here are cancer, or colonic cancer, and polyps, which are sort of precursors to cancers that neoplasias haven't had all the genetic mutations occur to them yet to make them a cancer. And there's also angiodysplasias, which are just vascular malformations or vascular leaky vessels in the colon that can also bleed. So there was a study done in patients with iron deficiency anemia, and this is the sort of seminal study from 25 years ago. It was such a simple study, but they got into New England Journal of Medicine. They just scoped 100 patients with iron deficiency, and they found that of those patients, 11 of them, so 11% of patients with iron deficiency had colon cancer. It's a pretty catastrophically terrifying number. So we scope every adult male and every postmenopausal female with iron deficiency. In premenopausal women, of course, premenopausal women undergo menstruation, and that means that they lose blood every month. And the question of how much this contributes to the iron status in women was studied in a very ambitious study done in the UK, where they actually collected they actually directly collected all the menstrual bleeding from 90 women, and they measured the iron content in the menstrual bleeding over a month cycle. And they also carefully measured the dietary iron intake. And what they showed, that it's actually the menstrual bleeding that is the bigger contributor to a woman's iron stores than the nutrition. So essentially, the main determinant of the iron status of a premenopausal female is actually the volume of menstrual blood losses. And one thing that we come across very commonly in our clinic are women who've had very heavy menstrual blood losses. And so there we have to think of one extra thing, which is, does she have a bleeding disorder? And you guys will eventually have a talk maybe here about haemophilia and bleeding disorders, but most haemophilias, well, all haemophilias really only affect males, with the exception of, so the main bleeding disorder that can also affect females is von Willebrand's disease. And von Willebrand's disease is a disease that's is several of these lectures. It's a very complex disease to explain. Suffice to say that it's a disease of a reduction in the protein that basically connects platelets to the bleeding surface. And it's been shown a few times now that in women with menorrhagia, about 20% of them have von Willebrand's disease. And indeed, in the only study that I found where they looked at the prevalence of von Willebrand's disease in patients with iron deficiency, it's about 16%, so it's in line with that. So it's something that I'm starting to think of more now, that if I meet a female who's had, a woman who's had several incidences of recurrent iron deficiency, we now test her to see if she's got a bleeding disorder. This is an iatrogenic cause of blood loss. So blood donors are valuable people. Many of you might be blood donors and they really help, but the blood service renders them iron deficient. So it's not rare. In fact, we've found that about 40% of recurrent blood donors are iron deficient. And of course, that's because every time they give blood, they lose 250 milligrams of iron, which is about a quarter of the stores that a person would have. So there's been a lot of research into the determinants of that, and no one's really pinned down why some donors escape and some donors become iron deficient, but it's a really fascinating area of further research. Finally, I think that it's important to think about iron utilization. So this is the National Health and Medical Research Council Australia recommendations for how much iron you should eat in a day. And I think this is one of the most striking things that you could ever see if you just look at it really carefully. So an infant, I don't know if any of you got kids or no kids, but babies are pretty small, they're about that big, and they're expected to eat 11 milligrams of iron a day. An adult male is expected to eat 8 milligrams of iron a day. In other words, that's because an infant has to grow. An infant has to, quadruple in size over the next few years. Meanwhile, a man hopefully shouldn't be growing too much. A premenopausal woman, meanwhile, needs 18 milligrams of iron a day, so much more than men. But I don't know, you guys have probably noticed men tend to eat more than women. And so just the actual concentration of iron in a diet that a woman requires ought to be a lot higher, but it doesn't happen. So the data tend to show that men eat far more than they need, and women don't tend to quite make it. And meanwhile, for young kids, an infant of 7 to 12 months and a boy of 14 to 18 are supposed to be eating the same iron intake. And I think we all know that that couldn't be possible. And that's really just because of the huge amount of growth that a child has to achieve over that first 12 to 24 months of life. And we actually showed in a study in Africa, I work also in Africa, and we did a study there, and we showed that the most important determinant of iron deficiency or iron status in an infant is their growth over the first 5 months of life. And this is just to show us, so this is just showing pregnancy. So this is the iron requirements in pregnancy. So during pregnancy, women have this huge iron requirement, particularly in the second and third trimester, because they have to do two things. Women have to make a whole lot of red blood cells, and they have to provide iron for their baby. And they do both of these things, so they have this catastrophic increase in the amount of iron they need, which as soon as they deliver, they don't need anything again. But it's during pregnancy, and that's why you see so much anemia and iron deficiency during pregnancy. So what do I do when I meet a patient with iron deficiency or iron deficiency anemia? So obviously we ask about their diet, we ask about the medication, the menstrual history, but and those are two important factors. But the other things that we really need to find out about are the blood donation history. We ask about the medications they're on. We do a celiac screen now in pretty much everybody. And in all male and postmenopausal females, we do scopes. We refer them for scopes. If the patient's already had scopes and we can't find the cause, and especially if the iron deficiency's happened a few times, we would also look for atrophic gastritis, looking for anti-intrinsic factor and antiparietal cell antibodies, which are associated with that. We might look for H. pylori, and we might look at the small bowel, which is another source of bleeding, but less commonly, but it does occur. The yield of that is relatively low, but it's something that people do. Now, how do we diagnose iron deficiency? So again, this is something that will become more part of your life as you go a bit further along. I think where I'll start with this is just to say that there's hemoglobin and mean cell volume. I've talked about that. So this gives you a microcytic anemia. This is what we do here. And then there's a whole lot of parameters that measure iron status in the peripheral blood, because, and the most important one that we do is a ferritin. And the ferritin, when it's low, implies iron deficiency. The problem with ferritin is that it's also an acute phase marker. So in a patient who gets inflamed, the ferritin is elevated, and then you can't tell if they're iron deficient or whether they're just inflamed or they've got both. And that's where it gets more tricky. But that's really the headline. I don't want to spend another 5 hours talking about that now. So the gold standard diagnosis of iron deficiency is a bone marrow examination. I would say we would never do that in a routine case in Australia, but we would do it in a patient in this condition, in the situation I just described, where it's a complex case where the patient might have inflammation and anemia. An example might be a complex dermatology patient that I saw when I was in the hospital, who's covered in, say, bullous pemphigus. You know, they're covered in these lesions. They've got an HB of 9, a ferritin of 1,000, and a mean cell volume of 70. So it looks like iron deficiency in the blood, but they've got just this insane inflammation. And so bone marrow there will help us work out if they've actually got iron stores or not. So this is what a bone marrow looks like. This is a pearl stain, and it picks up iron in the macrophages in the particles of the bone marrow. And this is an empty marrow without any iron in it. And this is what it looks like to do a bone marrow. So you guys will be doing these in a few years' time. But of course, a bone marrow is painful and difficult to use, and so we would only use it in the most difficult cases. So this is just something we published a few years ago, looking at the ways that clinicians should further investigate iron deficiency. So if you're interested, I can share that with you, but I won't bore you with trying to read out this table now. I want to get on to something a little bit more interesting, which is how regulation of systemic iron balance can actually be manipulated to come up with new ways to treat disease of iron status. So in 2004, or 2001, 2, 3, and 4, there were some seminal papers that basically uncovered that iron metabolism. I've just shown you a very sort of gastrointestinal story. You know, iron goes in the gut, gets absorbed, goes in your blood, great. But it's not that simple, because it turns out that iron is regulated by a very complex endocrine or hormonal system. And that hormonal system is governed by this peptide, hepcidin. So hepcidin is made in the liver, and it's secreted from the liver, and it can be upregulated by increased iron stores or downregulated by reduced iron stores. And it travels through to two important sites, the intestine, the duodenum, and the reticular endothelial system, the macrophages. And there it acts on ferroportin to inhibit its function and stop it from working. So ferroportin is the sole iron exporter. It's the only way you can get iron out of a cell. So if you have increased hepcidin and it acts on ferroportin, you block iron export from cells. And what that does is it blocks iron absorption and it blocks iron recycling. So if a patient is iron replete, they will have reduced ferroportin in those two sites and they won't absorb iron. If a patient is iron deficient, then they will have reduced hepcidin production, increased ferroportin, and they'll increase their iron absorption and utilization. So it's an absolutely wonderful system of endocrine regulation of a nutritional system. In fact, one of the first, really. So ultimately, what we can really start to reframe iron deficiency, disorders of iron overload as, are actually disorders of hepcidin regulation, which can either be pathologic or physiologic. So if you don't have enough hepcidin, if you don't make enough hepcidin, your body will absorb more iron. And that means that you will pathologically absorb more iron, and that occurs in patients with hemochromatosis or in patients with some forms of hemoglobinopathy. If you just ignore hepcidin and you say, well, I'm not going to use the gut, you can give people iron overload by transfusing them with blood too much. So that happens in thalassemia or patients who have become dependent on blood transfusions. Or if you just whack them with too much IV iron, which you can do, say, renal patients. So renal patients get IV iron every month because they like to have a lot of iron on board because they've got such sluggish EPO. And so we hammer them with iron, but then we make them iron overloaded. Or you could overwhelm your hepcidin, or it could be that your hepcidin is doing its best to get the iron in, so it's suppressed. But even so, you're not getting enough iron in. So if you just have a really low iron diet, so you live in Africa or if you live in India, and then you might not get enough iron in despite a low iron, a low hepcidin, or you might be utilizing all that iron. So you do take it in, but you use it. So you're a pregnant woman or just a woman or a baby, and you're doing as much as you can, but it's just not enough iron in your diet, or you're losing iron. Or finally, you can have pathologic hepcidin excess. And here what happens is you have hepcidin being elevated for another reason, and that reason is inflammation. Hepcidin is the most wonderful molecule because not only is it regulated by iron, it's also regulated directly by inflammation. And the reason for that is because hepcidin evolved not from any iron or nutritional system, but from an immune system, from the defensin system. It's actually a component of the innate immune system. And so hepcidin on its promoter has a whole lot of transcription factor binding sites for STAT3, which is an IL-6 transcription factor, just as much as it does for the iron regulatory pathways. And what that means is that hepcidin will be up in iron loading appropriately, but it will also be up if you're inflamed. And so what that does is it means that your body tries to keep iron out during inflammation. So in patients with anemia of inflammation, with chronic renal impairment, which is an inflammatory condition as well, or in patients with a genetic disease called iron refractory iron deficiency anemia, these patients have elevated hepcidins despite having low iron in their and that makes them look like they've got iron deficiency. And that's why anemia of inflammation and iron deficiency anemia can look like the same disease in the blood. So how does this work? So you can have diseases of too much hepcidin. So here you can have, this is the liver, and these are the signaling pathways on the liver that signal the different parts of the different pathways that signal hepcidin. So here you can have too much hepcidin because of systemic inflammation. So you have increased IL-6. You can have chronic kidney disease and reduced hepcidin clearance. So you'll get, or you can have a disease where you lose this protein here, TMPRSS6. And this protein here negatively regulates the pathways that cause increased canonical signaling of the pathways that respond to iron. I feel like I'm getting a bit complicated here, but anyway. And this can occur here with mutations here, and that causes iron refractory iron deficiency anemia. So this is just an example of this story. So in this study that was done a few years ago, in Africa, it's very common for people to have malaria parasitemia but seem perfectly well because they're immune-ish to malaria. So this was a study where they took women who happened to harbor malaria parasites, and then they measured the iron that they took in from their diet using a stable isotope dilution method. Then they killed all the parasites with parasite drug. They gave antimalarials, and then they measured again. And basically the iron absorption increased from 10% to almost 20% just by treating the malaria, because there was a reduction in the hepcidin that was being caused by inflammation. This is TMPRSS6, everyone's second favorite gene, and this is a gene that causes negative regulation of hepcidin, but when it's mutated, that doesn't happen. So this is a disease where there's a few diseases you'll learn about where there's more people who research than actually have it. This is one of them, and so diseases of TMPRSS6 cause patients to have what we call iron refractory iron deficiency anemia because they can't suppress their hepcidin appropriately the way they should when they're iron deficient. And what's really interesting is that those are mutations in TMPRSS6. But if I took all of you and the whole population, and I just looked at sequence your TMPRSS6 gene, what look like benign, just single nucleotide polymorphisms, so just SNPs, not mutations, but SNPs, they actually contribute to your iron status. In other words, there is a genetic contribution to your iron status, which is mostly determined by mutations in TMPRSS6. SNPs in TMPRSS6. So it's amazing that the genetic overlay to our iron status comes from regulation of hepcidin. So all that said, can we play with this system now and treat these diseases? And the answer is there's a lot going on in the space. Many of these drugs are in preclinical phase, which means by the time you guys are hematologists, you'll probably be using them. And some of them are just reaching clinical phase. So if you wanted to do this, the way you do it is by upregulating. So if you want to upregulate hepcidin action, this will be useful for treating diseases that are of iron overload. And you can do it in a few different ways. You can increase hepcidin transcription. You can mimic hepcidin by using drugs that look like hepcidin, or you can directly agonize the receptor. If you want to block hepcidin, and if you want to block hepcidin, what you're trying to do, you might do this if you're trying to treat, and this is where you want to use this to treat complex diseases that look like iron deficiency anemia. And here what you're trying to do is increase serum iron. So it's been tried a lot in patients with chronic kidney disease, anemia of inflammation, and chronic and cancer-related anemia. Here the treatment options at the moment are to treat the underlying cause, give iron, or give EPO. But there's some drugs coming that will work, we think, in this space, and they're just sort of coming now. So this is really way too much detail for you guys, but these are some drugs that have been trialed. And I think what I'll say is there's so many different molecular mechanisms. So one thing that you guys might want to do with your lives is develop drugs to treat diseases. And there's so many different ways you can do it. So these are proteins that bind to hepcidin and stop it from functioning. These are pegylated anti-kaolin proteins. You give them to patients and they increase the serum iron. And this is an antibody that does the same thing. You give the antibody to patients, it binds to the hepcidin and it increases serum iron, really as proof of principle. And we're now starting to see that these sort of approaches can improve hemoglobin. And this is another way that you can bind to the drug, bind to hepcidin and stop it from functioning. So these drugs are all coming, and I think they're going to be fascinating. This is a drug that acts on ferroportin directly, bypassing hepcidin to stop it from having hepcidin hit it. So I'm just in the last 5 minutes going to talk very briefly about my other passion, which is the population approach to anemia. So you've seen the slides at the start. There's a lot of anemia in the world, particularly in babies and in pregnant women. The way the WHO deals with this is to say, let's give iron to everybody. So they say give iron either as iron drops or as iron fortified multiple micronutrient powders. And so you've seen these. So this is what iron drops look like. You've probably met these before in your life. And this is a new way of giving iron, which is basically a sachet that contains iron that you pour on food so you can fortify food at home. So in developing countries, if you guys go to the supermarket here, you buy fortified food. It's already fortified. But even in a village and you're growing your own food, then it doesn't work that way. So this way you can fortify your food at home. But so WHO recommends that we give this to everybody in the population where there's a lot of anemia. So in those countries where there's a lot of anemia. But they don't say that you should do it based on the iron status. And so therefore what they expect is that some kids don't need it, some kids need it, and on average it's beneficial. So that only makes sense if it's safe and if there is a benefit. But there's another thing that needs iron, and that's bugs. So I don't know if you guys have done microbiology, but basically all of microbiology is, you've probably grown your own hands on microplates and all that. Basically all those media, what they really contain is iron. So they're basically packed with iron. What is that horse blood agar? I think what's the blood? It's iron. So basically bugs love to grow on iron. And unfortunately for us, if we're trying to give iron to a whole population of kids who live in countries where there's lots of infection, the possibility is that in so doing, we actually make those infections worse, and those infections are dangerous. So we have to weigh up the possible benefits on anemia, on child development or growth against the risks. So we did a systematic review just to suss out what the benefits were, and what we were stunned by was that no one had done the trials to suss out whether iron actually improves child development. And so there were only these really small studies, and when you add them all together, there was actually no evidence of benefit because the studies hadn't really been done yet. So we couldn't say that there was a benefit on child development, but there's some very important studies that have been coming out suggesting a risk. In particular, this study from a few years ago in Pemba in Tanzania randomized about 24,000 babies, tried doing that trial, and randomized them to iron with zinc or placebo, just to the whole population. And then what they did was they went and sat in the hospitals and waited to see who would die. So that's how you do a trial that big. And what they found was that when they gave the iron, it increased the risk. They thought it was going to save lives. That was the hypothesis of the trial. It wasn't meant to be going out and causing homicide. But what they found was that it was increasing the risk of serious adverse events, hospitalization and death by 12%. It increased malaria-related adverse events, and the trial had to be stopped early by its monitoring board. And this prompted an emergency change in WHO recommendations at the time to stop giving iron to populations in Africa. And that really caused a huge crisis in our field. In Pakistan, later on, they did another trial, and there they found that iron increased diarrhea and bloody diarrhea, and maybe even respiratory infections, but this trial didn't use a placebo. This may have occurred because there's now data suggesting that iron causes reprofiling of the intestinal microbiota, because it turns out that commensal species, your bifidobacteria and your lactobacilli don't need iron, but your pathogenic species are iron-philic. So your Shigellas, your Salmonellas, they love the iron. So there was a big concern about whether it's actually worth giving iron. And what we realized is that actually putting this whole story together, each of these trials is incomplete. They haven't really been done properly because they never really did a thorough assessment of the benefits and the risks together. So I just want to show you a little bit about where we're up to at the moment. We're doing a few trials now that are trying to address these questions. So we wanted to know, does giving iron address to improve anemia? Well, we know iron improves anemia, who cares? What we really want to do is, does it make the children better? And we need to do that in two types of place, in a non-endemic setting, a malaria non-endemic setting, so South Asia, and a malaria endemic setting, so Sub-Saharan Africa. So we're doing two trials, one in Bangladesh, just outside Dhaka, where, and we're doing another trial, and this is the BRIS trial, which is almost complete. It'll be ready next year. And here we're randomizing children to iron, all those micronutrient powders, or placebo as a double dummy. So it's highly placebo-controlled and highly blinded. And we're assessing child developmental outcomes at baseline end of intervention, and then after an extended follow-up as well. And in the meantime, we see the babies weekly and monthly to look for evidence of infection. And so this trial is collecting all that data to really give us a thorough understanding of the benefits and risks of iron interventions. In malaria endemic settings, the question is a bit different because we don't think it's safe to just give kids iron in a malaria endemic setting. So we need to think about a way to make it safe. So there we're adding an anti-malarial intervention to try to make the intervention safe. But the question is, once you add antimalarials, maybe malaria is worse than iron deficiency. So we need to be sure that it's not the antimalarials alone that are causing a benefit there. And there's a drug that you can use to prevent malaria, dihydroartemisinin piperquine, that we're starting to get very interested in. And so we want to see whether, firstly, reducing malaria makes the children better. And then if it does adding iron on top of that make them even better again? And to address that, we've got a 4-arm randomized controlled trial now that we're about to open in Malawi. And this trial will recruit 2,168 babies to placebo versus antimalarials. And then within the antimalarials, the same trial as the Bangladesh trial. And again, we're assessing child developmental outcomes as well as hematologic outcomes. Finally, just a last thing, there was a beautiful trial done in Kenya that showed that iron supplementation in pregnancy really helps. It really helps. It improved birth weight by 150 grams. Fantastic outcome and really aligns with the global health priorities. But the problem is in developing countries and actually in developed countries, no one takes their iron. People hate taking iron. It gives them gastrointestinal side effects, gives them diarrhea, constipation, they hate it. But in Melbourne now, we give this to everybody. We use intravenous iron. It used to be a really dangerous approach because intravenous iron used to cause anaphylaxis. You used to get over hours. You have to have adrenaline next to the patient. It was horrible. But now there's a new drug that we can give that we can correct the iron status in about 15 minutes with a single injection. We give 1,000 milligrams. So we thought we could try that out in Malawi. So we've been funded by the Gates Foundation to randomize 860 women to in pregnancy to a trial of oral iron versus IV iron. And we really want to see if we can improve hemoglobin at delivery and birth weight at delivery. And then we've just been funded to actually follow the babies out for 12 months and see whether the babies are bigger, stronger, faster, better. So we will see. And that is the first woman in Sub-Saharan Africa to receive ferric carboxymaltose. We've got lots of stuff that we can do with these studies. We're not just doing the studies, but we're also doing lots of ancillary studies at the WEHI, so microbiomes, genomics, inflammatory markers, immune studies. There's more sub-studies than you can poke a stick at, and we're always looking for people interested in helping us out with those. So ultimately what we actually take, the approach that I take in my division at WEHI is that we have an approach of using these population studies to apply these really hardcore modern techniques to make fundamental discoveries. And maybe in a couple of years I'll come and, when you've had your first round of normal hematology, we'll come back and I'll talk to you about some of this awesome stuff that we can do at the WEHI. Anyway, and the other thing we're doing is we're doing EEGs on 700 babies in case anyone likes neurology. So, so we've got just, we'll be able to do some quite amazing sort of microbiome, brain, genetic type studies as well. So this is what we do in our lab. We try to have a holistic perspective from basic science through to clinical trials, through to policy. Anyway, enough from me. So thanks for your attention, and I'll take any questions for a few minutes.
So thanks, Sant-Rayn, for a very insightful talk. I'm conscious of the time, and I know Sant-Rayn has another commitment later tonight. So we might have time for around 2 or 3 questions from the floor. I might just start off. I know that the WHO has set quite an ambitious target to reduce the incidence of anemia by 50% in women of reproductive age by to 2025, I think.
That's right.
So I guess my question would be, how realistic do you think that target is?
Completely unrealistic, but this is being taped. Damn. So don't play that to WHO. So it is unrealistic. So actually they're monitoring the progress of that. The Global Nutrition Report audited the performance of that after about 4 or 5 years of that target, and showed that of how many countries are there? 190 countries. 2 were on target and 189 were off target. And the current predicted time to meet that target is 100 years from now. So not on target.
Okay. Any other questions from the floor? Yep.
I was just interested in the study you looked at where they showed there was actually the harm in giving the whole population the iron. If you added zinc in at the same time, did that lower the mortality?
No, so they combined the arms and they showed there was no difference between the iron and the iron plus zinc arms. So what they actually did was that trial was actually, there was actually a fourth arm in there, which was a zinc alone trial. So what they did was they ditched the two iron arms and then just kept going with the zinc and zinc and placebo arms for that trial. But no, together it still didn't help. No, in that trial it was just 12. Sorry, there were two different doses depending on the age of the child. If they were under 6 months, I think it was, or under a certain age, like 6 months, it was a 6 milligram dose. Otherwise, it was 12.5 milligrams.
Iron deficiency anemia, does that have long-term complications for adults other than pregnant women?
That's a good question. I think that I don't. So most of the thought has been that the key irreversible effects occur in babies, for example, or even in utero, and that's where you have a lot of neurogenesis or nerve production, brain development, and that's where most of the interest has been. In terms of say an adult who becomes iron deficient and then say is corrected for that, at the moment I don't think there'd be a thought that is associated with a sustained long-term problem, but it's a very interesting question as to, I haven't actually seen the data about whether, if someone was iron deficient, obviously the key implication there, again, being filmed, is the blood service, where they're rendering, huge numbers of people iron deficient every day. But the entire premise of that being safe is that you can safely restitute it and then it's all fixed again. But it's a good idea, it's a good question.
We might have time for one or two more questions.
On the thought, thanks for that. On the thought of so malaria endemic countries and fortified foods that fortified with iron, has there been any, probably not a very common situation, has there been any research into the effects of fortified diets?
Yep. So no, there has been quite a bit on that. So the key issue with fortification is it depends on what you fortify. But if you think about what people eat, so the people who are iron deficient are the pregnant mothers and the babies. The people who eat all the cereals, like if you fortify wheat or maize, in Africa it's mainly corn-based maize. Who eats all that? Like who eats the huge amount of, because you have to fortify at the same concentration. So the guys eat all that, and the women, the babies get that much of it, and of course they need more. So fortification is a great strategy for maybe adult women and men to improve their iron status, but there are concerns about its value in little babies. But certainly it does, fortification, the large scale fortification studies usually show that it works for a while, and then for some reason it just stops working again, which might be down to quality, implementation, or maybe use of those sort of foods. John.
So I'm thinking of iron deficiency mainly in terms of kind of
Yep.
That's interesting. I just didn't know about that. If I start to talk about iron deficiency anemia in those terms on the ward, would they look at me like I'm silly, or is that something that's common knowledge?
No, it's common knowledge. So should be, depends if you're talking to a hematologist or maybe a gastroenterologist. But and if they're in the Royal Melbourne, they'll have heard of it because I've talked about it. But I think you could probably star in a teaching bedside teaching shoot if you talked about hepcidin. So basically, where there is a lot of interest in using hepcidin as a diagnostic to not so much tell you the iron status, but to tell you what's going to happen if you give iron to the patient, because it should determine how it's utilized.
probably all we have time for today. Can you please join me in thanking Dr. Pasricha? Yeah, great. I might let Dr. Pasricha duck off,
Cool.
but thank you so much. Thank you.
Yeah,
Not a problem.
Cool.
Thank
See
you.
you later.
So just before I let you guys go, just a plug for our next event. So it's coming up on Thursday, the 8th of August, and it's a seminar. We're inviting a BPT trainee and a registrar and a consultant to talk about the pathway to becoming a haematologist. And I'm aware that ASSH is probably one of very few, or perhaps the only sort of physician-based interest group here at the University of Melbourne. So we're really keen on inviting a BPT trainee to talk specifically about their experience as part of, as a BPT trainee, and what the BPT training involves. So yeah, just a plug for that. It's going to be on Thursday, 8th of August in the ESJ King Theatre upstairs. So thanks so much, guys, for coming along. We have pizza outside. And for those interested in sort of mingling with, like meeting a couple of people who share the same interest in haematology, we have some drink vouchers provided by PAs. So feel free, after grabbing pizza, to head along to PAs, and yeah. Awesome. Thanks so much, guys.